नेकी यही नहीं है कि हम अपने कि आप अपना चेहरा जो है मशरिक या मगरिब की तरफ कर दें, वलाकिन्नल बिर्रा मन आमन, बल्कि नेकी ये है कि कोई शख्स ईमान लाए बिल्लाह अल्लाह पर वल यौमिल आखिर और आखिरत पर वल मलाइका और फरिश्तों पर वल किताब और किताब पर वन नबिय्यीन और नबियों पर वआतल माला अला हुब्बिही ज़िल कुर्बा और अल्लाह ताला की मोहब्बत से माल खर्च करे रिश्तेदारों पे वल यतामा और यतीमों पे वल मसाकीन और मिस्कीनों पे वल सबील और मुसाफिरों पे वफिर रिकाब और गर्दनों यानी गुलामों के छुड़ाने पे व अकामा सलात व ज़कात और नमाज कायम करे और ज़कात दे वल मूफूना बिअहदिहिम इज़ा आहदू और अपने वादों को पूरा करें जब वो करेंगे बस साबिरीन फिल बासाइ वद्दर्रा और सब्र करने वाले मुश्किल वक्त में और परेशानियों में वहीनल बास और जंग में उलाइका लज़ीना सदक़ू ये वो लोग हैं जिन्होंने सच्चा कर दिखाया अपना वादा व उलाइका हुमुल मुत्तक़ून ये वो लोग हैं जो मुत्तकी हैं सदक़ल्लाहुल अज़ीम। I think the workshop is being conducted by Dr. Danish Bhatti. He needs no introduction, but still a few words. He's a graduate of King Edward Medical University. Then he did his neurology residency from Nebraska, University of Nebraska Medical Center in Omaha. Then he did the fellowship in movement disorders over there, and then he got promoted to the associate program director for the fellowship program. He served there for a few years. Then he has recently moved to Florida, and I have the honor of actually learning from him both here in Pakistan and also over there in Nebraska. And he has been a great student, a great mentor and helpful teacher for all of us here, and he has been coming to Pakistan many times. So it's a pleasure that we have him here physically at this year's meeting. So what we would like to do is to invite him to comment on some of the videos that we have chosen for this session. But I will also encourage you to participate and give your comments, because this being a small group discussion, I think it should not be a one-way discussion. It should be as interactive as possible. So the rest, I think I'll hand it over to Dr. Danish, and then he'll take it from there.
Right. Thank you, Abhi. Assalamu alaikum, everyone. तो आप लोग कोई मर्जी से ये मजबूरन यहाँ पहुँची है, तो let's take the best use of time. तो जना आप भी आए, मैं भी आऊँ, but let's not do it just for the sake of doing it. I am happy to share any knowledge or skills I have, which is not a lot, but a few. So feel free to ask anything. The whole purpose of this exercise, maybe बाद में शायद अच्छा खाना भी हो, लेकिन the main purpose of the exercise is to learn a few points, right? And see if there is something useful 6 months from now, a year from now, that will help you in a tough time. हम सारे हमारी जो passion है और जो job है, वो figuring out complex neurological patients है. The goal of this exercise is to see if there is a tip or a trick or a piece of information that will come out of blue in the right time and save you a headache, solve a puzzle for you, make a difference in someone's life. So that's the whole goal and whole purpose. So I'm happy to be here, 7,000 miles from home, and I'm here for the next hour and a half to 2 hours or so. Take best use of it. Stop me anytime, ask me any questions. I will try to myself give you what I think is useful. लेकिन maybe what's useful for you, you know better. तो आप मुझे पूछें या रोकें कि जी ऐसे मुझे ये बता दें, या this is kind of things I get stuck in. Movement disorder. Outside of movement disorders, I'm probably at best only as good as you, or probably worse than you in many of these things. So in movement disorder, I might have a few things that I can tell you. So feel free to ask me. I was thinking, Nabil, if it's okay with you, we have a patient here in person. Why not we take respect his time and just start there. And let me do a brief context, and then we can talk to the patient. मूवमेंट डिसऑर्डर्स जो है वो न्यूरोलॉजी की वो फील्ड है जिसके अंदर हम एबनॉर्मल मूवमेंट्स को, यूजुअली एक्स्ट्रा मूवमेंट्स को डील करते हैं. वेरी फ्यू डिक्रीज मूवमेंट्स हैं, क्योंकि डिक्रीज मूवमेंट्स की अक्सर कॉज जो है वो नॉन मूवमेंट डिसऑर्डर होती है. स्ट्रोक हो गया, न्यूरोमस्कुलर हो गया, एमएस हो गया, all of them are movement disorders, right? They will affect the movements. The reason we don't call them movement disorders is that they have a defined pathology, and then usually it's a loss of a specific function of a nervous system. Movement disorders are usually hyperkinesia, increased movement, although there are few hypokinesia, very few, so they are. And then the other thing is that often there is no obvious cause identifiable. आप scan करते हैं, MRI करते हैं, कुछ नहीं होती. 99% of them are, 95% of them are basal ganglia disorders. 5% are outside, but still in CNS. There's only 3 movement disorders which are peripheral nervous system movement disorders. Okay? One will be the restless leg syndrome. We think it's related to neuropathy in some cases, at least maybe 30%, but not always. Many it's unidentified. Iron deficiency can cause restless legs, in that sense it's central. Central iron deficiency is hypothesized as a cause, but neuropathy can cause restless legs, so that's one. The other is neuromyotonia, and then the third one, which is a form of neuromyotonia, is a Schwarzenegger syndrome, which is a neonatal onset of neuromyotonia. Except for these 3, and then sometime there is some forms of myoclonus which are peripheral, induced myoclonus due to neuropathy something, but majority of myoclonus is also central. But except for these 3, all movement disorders are central. 95% of them are in basal ganglia, which is the caudate, putamen, globus pallidus, intestine externa, subclavian nucleus, red nucleus. All of that structure is the basal ganglia. So how do we deal with movement disorders? So we use a 2-step approach, which is usually different than most other parts of neurology. Because for us, a movement disorder is a little tough because you're not used to thinking that way. We divide movement disorder diagnosis into 2 steps. The first step is to diagnose or identify the phenomenology. कि जो movement हो रही है वो क्या है? That is not the actual diagnosis, right? So a tremor could be Parkinson's disease, a tremor could be essential tremor, a tremor could be dystonia, could be stroke, myoclonus, drug induced. All of those are the etiology, but tremor is the phenomenological diagnosis of phenomenology. बड़ों ने मूवमेंट डिसऑर्डर्स के एक लिस्ट बना दी है कि जी ये है फिनोमेना, इसके अंदर फिट करो. बाज़ बार हम फंस जाते हैं, we find things that just does not fit with anything. फिर बहस हो जाती है, मूवमेंट डिसऑर्डर कहता है कि जी ये तो डिस्टोनिया, दूसरा कहता है कि ये डिस्टोनिया नहीं है, ये माइक्रोनस ट्रेमर है. कुछ में तो सिर्फ सब्जेक्टिव डिफरेंसेस होते हैं, कुछ में ऑब्जेक्टिव इश्यूज हैं. फॉर एग्जांपल, पैलेटल मायोक्लोनस is now being considered as a tremor. कि जी ये पैलेटल ट्रेमर है, मायोक्लोनस नहीं है. I can go into detail क्यों, लेकिन maybe this is not the time. So step 1, identify the phenomena, and they may not be one, they may be more than one phenomenon. For example, a Parkinson's disease diagnosis, often the phenomena are multiple. Number 1, bradykinesia, which is a decreased movement, hypokinesia. Then there is a tremor, a resting form of a tremor, a very peculiar tremor, that is a hyperkinesia. There is often dystonias or choreas, which is sometimes drug-induced, sometimes levodopa-induced, sometimes so dystonia can be either levodopa-induced or even levodopa-responsive. Goes away with levodopa, but levodopa can cause dystonia, right? So dystonias may be present, they may be ataxia, they may not be. So posture instability, 4th pillar diagnosis is actually a form of ataxia, frontal ataxia, patient teaching it. Then there could be myoclonus, sometimes levodopa causes myoclonus, sometimes forms of Parkinson cause myoclonus, sometimes the MSA है क्योंकि myoclonic tremor है, resting tremor नहीं है, so on and so forth. But the point is, a Parkinson's disease or same diagnosis, same disease may have more than one phenomena. So step 1, identify and diagnose each of the phenomena that you're seeing, and that is the hardest part. क्योंकि बाज़ औक़ात movements इतनी ज़्यादा होती हैं, इतनी complex होती हैं, you have to slow things down and break it. अब ऐसे ही है बिल्कुल मेरे ज़हन में जैसे एक slow motion movie चल रही. I'm trying to freeze it down, slow it down, break it. अच्छा ये है. To give you an example, तो imagine जी tremor है, but tremor है कहाँ है? Is it at the fingers? Is it at the wrist? Is it at the elbow? Is it at the shoulder? कहाँ है? और mix it. Maybe it's a combination. Maybe वो vary करता है. कि resting पे यहाँ पे, hand holding पे यहाँ पे, hand holding पे. You have to break it down everything. You can say, okay, gee, they have a wrist extension flexion tremor with the hands up there, but when they come close, they become an elbow extension flexion tremor with palms up. they become a pronation, supination tremor. So tremor may actually change the kind of tremor based on the position, something like that. So you have to break down everything. So again, you can say tremor diagnosis. You have to then say, okay, describe the tremor. That's why we use the word phenomenology, which basically means description of movement. You have to describe the movement. उसमें भी बड़ों ने help कर दी है कि there is actually a list of things that you describe a movement with. कि उसकी speed क्या है, उसका amplitude क्या है, उसकी anatomic location क्या है, वो किस rest पे है, कि action पे है, और वो जो है suppressible है कि नहीं suppressible, rhythmic है कि non-rhythmic है, variable है कि नहीं है, continuous है कि continual है कि intermittent है, paroxysmal है, so on and so forth. आपको नेट से सारी चीजें मिल जाएंगी, इसकी मैं इतनी डिटेल में नहीं जा रहा, नहीं तो नबील से बताऊँ. Anything that's missing, we will provide. ठीक है, तो जो है ना वो you can start there, but often that's not enough. Once you start seeing a lot of movement sort of patient, वो फिर आपको ऐसी observations करनी पड़ती हैं जिसमें नहीं है. For example, you know, one of the things my mentor used to do कि वो patient से पूछता है कि जी किन situation में आपको वो abnormal movement होती है, then he asks them to do the situation, right? For example, they say, you know, whenever I walk, I see this problem. Or when I do, मेरा एक patient है, आया ट्रेमर के साथ, पहले मैंने उसको देखा, भाई ट्रेमर नजर नहीं आ रहा, वो कह रहा है मुझे ट्रेमर की कंप्लेंट नहीं, शायद मिस रेफर हुआ कि वो ट्रेमर कह के बेचते हैं, वो एकथीसिया होता है, रेस्टलेस लेग होता है, कुछ और होता है, पेशेंट नहीं जा रहा मुझे ट्रेमर है और ये है, तो यार होता क्या बेटा, वो कहता है कि जी मैं जब स्टूल पर चढ़ के ऊपर स्क्रू ड्राइवर से टाइट करता हूँ, ठीक है, मैं इलेक्ट्रिशियन, उस वक्त ट्रेमर आता है, मैंने कहा उठो, सो खड़ा करो चेयर पे, सो इमेजिन ये जो ना टंग डिप्रेसर है, स्क्रू ड्राइवर, शो मी. And then you start saying, oh, it's a dystonic tremor, position specific, very task specific, gradually becomes secondary generalized and so on and so forth. So you have to reproduce. अभी वो आप लिस्ट में तो नहीं एग्जाम में कि जिसको स्टूल पे खड़ा करके ऊपर स्क्रू ड्राइवर से टाइप करवाना. We have to do those things, right? If a musician है, आपको उसको म्यूजिक, तो इंस्ट्रूमेंट लेके आओ साथ. अगर म्यूजिक में प्रॉब्लम है, किस चीज में प्रॉब्लम है, you have to try to reproduce that. तो एग्जामिनेशन उस लिस्ट से ज्यादा है, but list is a good starting point to say movement क्या है. और then the categories की लिस्ट है, वो भी आपको नजदीक से मिल जाएगी. जो आप यूज कर सकते हैं to try to quantify ये movement है. जब वो जमा हो जाए, then you start thinking कि क्या possible etiologies हो सकती हैं इस movement disorder की, इस diagnosis की, and then you start making that list, and then you start doing the workup and so on and so forth. Sometimes it's obvious, sometimes etiological diagnosis is very hard. You just have a tough time getting to which cause क्या कर रहा है, microns कहाँ से रहा है. Sometimes it's obvious, drug-induced microns, the most common cause of micron is 70% of microns presentation. 100% on the floor inpatient microns is drug-induced microns. So, लेकिन बात अगर more complex है, this myoclonic dystonia genetic syndrome DYT 11 and 13, तो वो उस तक पहुंचना बड़ा मुश्किल हो जाता है कि this myoclonic dystonia or something like that. So on and so forth. So with that, I will start unless someone has questions. Anytime you have a question, just raise your hand. I will try to pause and ask you if you have a question and try to add that information. Okay? Alright, don't hesitate. I was a patient है जो आए हैं, क्या नाम है आपका? जी अब्दुल रज़ाक. Please बैठ. तो हम अब्दुल रज़ाक आपका एग्जामिन कर लेते हैं. चूँकि I'm not going to do full consult, मैं आपको हिस्ट्री के लिए आए होगा, no clue, history anything like that, right? Etiological diagnosis के लिए ज़रूरी है. You need to have information. Tremor की my mentor, Dr. Torres, has a very nice teaching where he explains young onset tremors कौन से होते हैं, middle onset कौन से हैं, later onset कौन से हैं, कौन से symmetric होते हैं. I'm not going to go into that, so I'll show you the examination. I'm going to literally go blind, and I have not seen this patient before. आपका थोड़ा सा मुआयना कर लीजिए. बिल्कुल से आप थोड़ा सा नीचे कर लूँ, बैठे रहें, मेरी तरफ मुँह कर लें, और हाथ सामने रखें. अपने जिस्म को बिल्कुल ढीला छोड़ दें. अगर मूवमेंट हो रही है, कोई हरकत हो रही है, उसको होने दें, उसको रोकने की जरूरत नहीं, घबराने की बात नहीं है. यही टाइम है कि मैं उसको देख सकूँ. क्योंकि दूर से आए तो अच्छा है कि मुझे वो सारी नज़र आ जाए, बिल्कुल बेफिक्र हो, उसको रोकने की कोशिश ना करें, और आंखें बंद कर लें और जिस्म को बिल्कुल ढीला छोड़ दें. So some things hit me right away. Again, I'm now going to jump and not follow the pattern of examination, just based on how I'm observing. वरना जो pattern है वो आपको videos पे मिल जाएगा. Quickly, I'm noticing that right shoulder is asymmetric from the left shoulder. The right shoulder is higher than the left shoulder. That could mean that he has bradykinesia on the left side and has a drop of shoulder, or he has a dystonia on the right shoulder, causing the shoulder to be elevated, pulled up. We can see the tremor. I'm not going to details right now. I'm just observing if there is any tremor anywhere else. आंखें आप बंद रखें, ठीक है, और मुझे उल्टी गिनती सुनानी है अपने 20 से पीछे की तरफ। 20 से गिनना है, पीछे की तरफ गिनना है, आगे नहीं पीछे। आंखें बंद रखनी है। हाँ, 20 से पहले क्या आता है?
20 से पहले
हाँ, फिर पीछे जाएं,
18
जाते जाएं।
17 16 15 14 13 12 11 10 9 8 7 6 5 4 3 2 1।
बिल्कुल सही। मैं साथ साथ बोलता जाऊंगा जो भी चीज़ सोच रहा हूँ, क्योंकि जो ना some things are may not be obvious. Distractibility is important to bring out other movements, although I ask him to just relax and let it go, but subconsciously we're always suppressing, especially when we are being observed by so many people. So the things I noticed was that he had lifting of the left thumb, वो हाथ रख के बैठा हुआ है बिल्कुल नीचे वेस्ट पे, तो कोई ज़रूरत नहीं है कि आप अपना अंगूठा ही उठा लेंगे एकदम बात करते करते, राइट? तो दैट मीन्स दैट unconsciously either he's thinking of something, mimicking a movement or something, or he's posturing. Posturing is another feature of dystonia. I see some shaking of the leg too. Now it could be a conductive tremor, कि right hand इतना जोर से हिल रहा है कि I feel कि right leg हिल रही है, or it may be a real right leg tremor. So अब मैं आगे examination ये करूँगा कि जब मैं उसके right hand को move कराऊँगा, I will keep part of my eye on the right leg to see कि जी वो tremor फौरन डिसअपियर हो जाता है, तो कंडक्टिव ट्रेमर के ज़्यादा चांसेस है, ट्रांसमिसिबल ट्रेमर है हाथ की वजह से। ये कई दफ़ा ऐसा होता है कि ट्रंकल ट्रेमर बहुत ज़्यादा हो ना, और बॉडी बहुत ज़्यादा हिल रही हो, तो समटाइम यू फील देयर इज अ हैंड ट्रेमर, बट मे नॉट बी प्रेजेंट, मे बी ओनली शोल्डर इन्वॉल्वमेंट, मे बी नो शोल्डर इन्वॉल्वमेंट, सो you know things you can get fooled, so you have to reconfirm. So rule number 1 or 2 or 3, कि any abnormal movement that you see in an examination, you must reconfirm it at least once or ideally twice to be sure that that's a real movement and it's not something that they are compensating or creating or stressed out or something like that. अगर मैं कोई एक चीज़ एक ही दफ़ा सिर्फ देखूँ, जैसे इसका लेफ्ट थंब की एलिवेशन मैंने देखी है, if I don't see it again, I will note it in my note ताकि मुझे कल को याद रहे कि इसको फॉलो करना है, but I would not call on it कि जिसको लेफ्ट हैंड का डिस्टोनिया है, डिस्टोनिक posturing or something like that, right? डिस्ट्रक्टिबिलिटी की मैंने बात कर दी। और तीसरी चीज़ मैं बताना चाह रहा हूँ आपको कि when I am examining the patient, I am trying to look everywhere at the same time. Movement disorder examination में peripheral vision develop करना बहुत important है, बहुत ज़्यादा important है कि to a point कि when if I'm typing something on a computer and I see something happening to the patient, I want to catch it up right out of my peripheral vision. I still want to catch it up कि उसको कोई jerk हुआ, कोई tick हुआ, कोई movement हुआ, कि बात चीज़ें इतनी intermittent होती हैं कि जब आप देख रहे होते हैं वो नहीं आती, right? और sometimes, you know, for example in psychogenic tremor, it will be helpful clue कि वो हर एक्शन करते हुए ट्रेमर हो रहा है, लेकिन जब आप टाइप करने लगे कंप्यूटर पे, उसने अपने पर्स में से टिश्यू निकाला और ट्रेमर कोई नहीं हुआ। Immediately make a note of it कि जी ये examination में find everything is an examination, not just when you're asking the patient throughout the visit, when you walk in, when they walk in, and so on and so forth. But you have to have a peripheral vision to look at everything. मैं जब उसके और कई दफ़ा मैं जो टास्क पेशेंट को देता हूँ कि जी हाथ उठाओ, ये करो, वो करो, मैं उधर नहीं देख रहा होता, मैं देख रहा होता उधर, but that's not what I'm paying attention to. Because I want to see sometimes patients में ये weakness होती है कि वो अगर suppress कर रहे हैं movement कहीं तो वो show हो जाती है while they're focusing on another movement, और अगर वो create कर रहे हैं movement तो वो disappear हो जाती है while they are focused on a certain movement. हाथ सामने रखें, आंखें बंद करें, जैसे इनको ढीला छोड़ दें, बिल्कुल इस तरह करें, आंखें खोलें और थोड़ा सा चेयर में आगे हो जाए ताकि आपके पीछे टेक ना लगे। चेयर वहीं रख लेते हैं, खुद आपने आगे होना ताकि टेक ना पीछे लगे, और बिल्कुल सही, और आंखें बंद कर लें। बिल्कुल सही, आंखें खोल, ठीक है, हाथ सामने कर ले दो, और हाथ ऊपर करें, आर्म्स अप, क्लोज टू चेस्ट, आपने जिससे भी पास करना है टच नहीं करना, बिल्कुल उस तक उड़ जाए, बिल्कुल। You can again asymmetry की मैंने बात की, watch the asymmetry. You can see the space between the third and fourth finger, fourth and fifth finger. You see no space there, sorry, no space there, right? तो मैंने shoulder की पहले बात की, लेकिन आप देखें asymmetries आपने pick करनी है. Maybe some of that is normal. You know, I'm not making judgment right away, but I'm trying to pick up all of that information. Again, you probably saw the tremor went away as soon as he lifted the arm, but it has not come back. Or the tremor now is different characteristic compared to the tremor before, right? हाथ सामने कर लें आप और हथेली ऊपर करें, बिल्कुल सर, हाथ ऊपर ले लें, बैठे, हाथ ऊपर ले, साइड से ले लें। Some of you may have picked head tremor, right, while he's doing the other tasks, right, and a slight left hand tremor which was not visible before. हाथ ऊपर ले लें. You see the left hand tremor, right? A very slight distal left hand tremor which was not there before, and a head tremor which was not there before. Part of it is distractibility, part of it is being I'm putting a stress on the system, trying to tire him out ताकि जो है ना चीजें निकलें जो वो हो सकता है छुपा रहा हो. बिल्कुल. हाथ नीचे कर और सर को पूरा दाएं तरफ मोड़, सीधा देखिए, सामने सीधा देखिए. और शोल्डर नाउ यू कैन प्रॉब्ली सी बेटर, पहले मेरी तरफ से सर को दाएं तरफ मोड़, ओके, फिर सीधा देखिए. आपको एक और चीज़ दिखाता हूँ, ऑब्जर्वेशन. रेंज ऑफ मूवमेंट में चेक कर रहा हूँ, राइट. सो नॉर्मल मूवमेंट इज द 90 डिग्रीज, राइट. इन हिम इट अपीयर्स 90 डिग्रीज, इट डज, बट for a true 90 degrees movement, the shoulders should remain stable, steady. There will be a compensated movement if there is a limitation. अगर मैं यहाँ से आगे सर नहीं लेके जा सकता और मैंने पुश करना है अपने आप को, तो मेरा शोल्डर आगे मूव करेगा to try to force myself, right? So if you're not paying attention, you'll miss those kind of things, right? So गिला छोड़ दें, आंखें बंद कर लें, बिल्कुल रिलैक्स, आंखें खोलें, सर को दाएं तरफ मोड़, पूरा दाएं तरफ मोड़, और पूरा बाएं तरफ मुड़े, बिल्कुल सामने देखें, सर को पूरा नीचे ले जाएं और पूरा करके हाथ सामने करके सर ऊपर ले, पूरा ऊपर और पूरा नीचे, बिल्कुल सर नीचे, हाथ नीचे. मैंने हाथ ऊपर क्यों करवाया? ठीक है, आई एम ट्राइंग टू पिक अप दैट हेड ट्रेमर, इज इट रियल और नॉट, जो मैंने पहले देखा था. अब मसला ये है कि राइट हैंड ट्रेमर इज सो बैड इट कैन इजीली कॉज ट्रांसमिसिव ट्रेमर, बट वी सॉ कि वो जो ही हाथ ऊपर करता है वो चला जाता है. आई मेड हिज हैंड्स कम अप बिकॉज आई वांट टू मेक श्योर कि जी हेड ट्रेमर रियल है कि नहीं है और किस सिचुएशन में है, पीछे जाने से कम होता है, ज़्यादा होता है, एंड सो ऑन सो फॉर्थ, राइट.
मैंने काफ़ी डॉक्टरों पे गया कराची में, एक मुझे सब ने पाकिस्तान बोला, सिर्फ बशीर साहब ने पाकिस्तानी बोला.
गुड डॉक्टर.
और सब मुगल शरानी खान पता नहीं किधर किधर गया था, सब ने पाकिस्तान बोला.
नहीं, आपने बेस्ट डॉक्टर को दिखा लिया. हाथ नीचे करें, बिल्कुल सही. अब सीधे हाथ से अपने हाथ सामने करके पहली उंगली अंगूठे को जोर जोर से हिलाना, तेज तेज, पूरा खोलना, तेज तेज, पूरा खोलना, बिल्कुल सही. लेफ्ट हैंड बिल्कुल सही. राइट हैंड से. अच्छा, एक और चीज आप नोट करें, मैं आपको वैसे टिप्स बता रहा हूँ रैंडमली क्योंकि पूरी मूवमेंट शॉर्ट में नहीं बढ़ा सकता. टिप ये है कि इफ यू आर चेकिंग फॉर ब्रेडिकाइनेसिया, राइट, यू लुकिंग फॉर फिंगर टैप एंड ऑल दैट, जो कि मैंने पहले भी चेक करनी थी बिफोर ही हैड ब्रॉट इट अप. A simple tip to remember is that in a hypokinesia, in a bradykinetic patient, all movements are bradykinetic, are reduced, right? तो finger tap ही खाली कम नहीं होती, उसका जो elevation है to the shoulder is also. So a hypokinetic arm is usually slightly below the shoulder, while a normal arm is at or slightly above. The other reason you see the hand above is dyskinesia. Patient जो पार्किंसन का आता है ना, और डिस्कनेटिक और हिल रहा है, उसे कहते हैं फिंगर टैप करो, वो इधर जाके करता है. That is hyperkinesia. So आपको वो गेज दे रहा है कि मेरा डोपामिन लेवल किधर है, मेरा यहाँ पहुंचा हुआ है कि मेरा यहाँ पे है, यहाँ पे, और पार्किंसन पेशेंट का यहाँ पे हो. You can actually almost relate कि इसकी dopaminergic state क्या है by just looking at कि how high he lifts his hands up. So his hands, you can already, finger tap पे decrement तो नहीं है और hesitation भी नहीं है, but you can already tell that the left hand finger tap was above the shoulder, slightly above. That means that it's a normal person or slightly hyperkinetic person.
सर दूसरा ये है कि मैं पौना घंटा शाम को वॉक करता हूँ. जब वॉक करता हूँ तो शुरू में थोड़ा यहाँ से दर्द शुरू होता है, हल्का महसूस हो रहा है यहाँ, उसके बाद जब गर्म होता है वो हिलना भी बंद हो जाता है और दर्द भी खत्म.
ठीक. So far, based on what we have seen, there is no obvious signs of bradykinesia. There is a unilateral tremor that seems to be present at rest, seems to go away with the arm movement, but has a difference in character based on the position. Different down here, different out here, different close to it. Is also posturing in the hand, which is most obvious on the right side. There is less obvious but possible posturing on the left hand, not fully verified. And then there is a slight head tremor, which is also jerky side to side, and a slight distal hand tremor jerky that occasionally shows up. अब ये मेरे ज़हन में एक baseline बन रही है. Now, if I continue to examine this patient, and my examination may be 30-40 minutes long, I'm reconfirming some of these things during gait, during other tasks. For example, अगर मैं unsure हूँ tremor के बारे में, often I watch the hand tremors while doing foot tapping. मुझे कहता हूँ जी पाँव जोर जोर से मारो. Or if I want to distract him more, I may encourage him to do more complex form of tapping. For example, heel toe tapping, tap heel and toe first, so on and so forth. But the goal is now I have a baseline. So my current working diagnosis will be a dystonic tremor with multifocal dystonia. It's maybe neck dystonia, maybe left arm dystonia. Right dystonia is more obvious. There are three kinds of tremor that have rest component. The resting tremor of Parkinson's, of course. But the rubral tremor will be other, which is a modified form of dystonic tremor, and dystonic tremor itself. Rarely myoclonic tremor can be at rest, it's not very common, and almost no other tremor is at rest. But not only Parkinson's have a resting tremor, there are other resting tremor. Most obvious one that not to forget is dystonic tremor, often has resting component, especially rubral tremor, which is I think is a form of dystonic tremor, always have a resting component. Always have a resting component. So you have to have a broad differential. When you see a resting tremor, can't always be Parkinson, although 99.9% time you will be right, but that 0.1% that is not, you will miss it. You will make a mistake. So although it's asymmetric, although it's unilateral onset, although it has a rest component, it is still not a Parkinsonian tremor because there is dystonic feature associated. There is a head tremor that shows up, left arm shows up. There is no bradykinesia and so on and so forth. So I'll pause here and see if anybody has any questions.
Can we make him walk?
Okay. डॉक्टर साहब कह रहे हैं कि थोड़ा चल के दिखाएं, ठीक है? आपने इस तरह करना है कि इस तरफ से चलना शुरू करना है और उस दीवार तक जाना है और फिर वापस आना है, 2-3 चक्कर लगाने हैं, बिल्कुल नॉर्मल चल.
इसको रोक सकते हैं? हाँ, रोक सकता हूँ. ओके.
दिखाएं रोक.
ओके.
सही. और अब एड़ी पे चल के दिखाएं. एड़ी के ऊपर, एड़ी पे रहना है, पंजे नीचे टच नहीं करने चाहिए. एड़ी पे चलते हुए जाएं. दोबारा एड़ी पे. ओके. एक मिनट वहां खड़े होंगे. Why this is not a psychogenic tremor? Distractive कुछ तो है. वो कहता है मैं रोक लेता हूँ, बैठे हुए भी वो रुक जाता है. हाँ. So why is not a psychogenic tremor? Why am I calling it a psychogenic tremor? So rule number 1: if you are a resident, you are never allowed to diagnose a psychogenic movement disorder. Never. Okay? Because you'll always be making a mistake. Again, just because something is unusual or strange, I have not seen before, nobody else has seen before, does not make it a psychogenic movement disorder. It is a positive diagnosis. You have to have features present for supporting it and absent features that does not support it. What does not support a psychogenic tremor? Patient who will cause a psychogenic tremor right hand will not give you a shoulder elevation. Why would he have a shoulder elevation? उसको तो नहीं पता कि dystonia में shoulder भी elevate होना चाहिए. Number 2, the overflow. In dystonia, classic feature is overflow worsening of the movement. जब वो एड़ियों पे चला, क्या चीज वर्स हुई? उसकी arm swing disappear हो गई. Loss of arm swing is increase in rigidity. A decrease in rigidity, arm swing become excessive, hypertonia, right? Increased rigidity will make the arm swing less. So वो normal चल रहा था तो उसकी arm swing थोड़ी बेहतर थी, और जो ही वो एड़ियों पे चलना शुरू हुआ, उसकी arm swing रुक गई, कम हो गई और शोल्डर एलिवेशन स्लाइटली बढ़ गई. दैट कुड बी सब्जेक्टिव, डिबेट हो सकती है, लेकिन उसकी आर्म स्विंग रुक गई. दैट मींस रिजिडिटी वेंट आउट. अब वो साइकोजेनिक पेशेंट को तो नहीं पता होगा कि मुझे कम करना है, वो तो चलते हुए शायद ज्यादा करे कि मैं गिर ना जाऊं एड़ियों करे. सो दोस काइंड ऑफ थिंग्स यू हैव टू वॉच फॉर. आज
Danish, how frequently does he blink?
Is that I have not noticed. Blinking हो सकता है blinking कम हो, but that's not something that you can rely on. And in his case, if blinking is abnormal, more or less, I would first think of blepharospasm before I even go for hypokinesia or bradykinesia causing the reduced blinking.
दानिश साहब मुझसे पूछो कि ये हुआ क्या, किस तरीके से हुआ, ये सवाल
ये हुआ क्या, किस तरीके से?
ये हुआ था, एक तो मैं डिप्रेशन का मरीज था, एग्जाइटी का मरीज था, डॉक्टरों को ये पता नहीं था, ये भी बशीर साहब ने पकड़ लिया।
MRI हुआ?
हाँ हमारा ही हुआ है, सिटी स्कैन भी हुआ है, हमारा ही भी हुआ है। तो एक हमारा पठानों के वो है मेहमान खाना है, बड़े बड़े तकिए होते हैं।
हाँ।
तो मैंने वो बड़ा तकिया खींच लिया, उस पे सो गया। उस पे जब सो गया पत्थर की तरह था, 2 फुट था। सुबह उठता हूँ तो ये सिलसिला शुरू।
So MRI is important. Why? Yeah, unilateral dystonia or hemidystonia is always structural until proven otherwise. वैसे इसका hemidystonia नहीं है क्योंकि इसकी मेरे ख्याल में neck और arm involvement left भी slight है. So it's a multifocal dystonia, not a hemidystonia. But a hemidystonia is structural until proven otherwise. सिर्फ right arm and leg में है, अब नहीं दूसरी तरफ जा रहा. Rule out a stroke or something else.
So, ये history of sudden onset, does this fit with dystonic tremor?
No.
रात को सोए सुबह उठे and you have tremor.
No, लेकिन stroke और important हो जाता है, right? Acute onset of dystonic tremor, you have to make sure there is no stroke. Rare cases of spinal cord lesion with dystonia have been reported, but it's not a common presentation. बिल्कुल ठीक है. Good. Another reason for MRI in dystonia always, the brain iron accumulation, calcification, magnesium, manganese deposition, Wilson's disease, so on and so forth. All right. I think we can move on to another case unless there's any question.
बस एक comment है psychogenic होने वैसे भी usually right side को involve नहीं करेगा या right handed person तो disability बहुत हो जाती है. Just a comment.
So, if this is a dystonic tremor, multifocal, how will you treat it?
So, tremor medications are usually the first go-to choices. Levodopa trial करना useful होता है. Usually doesn't work, but in generalized dystonias are more useful work. Then my go-to drugs are either Primidone or trihexyphenidyl, जो Artane है, and then we'll try other random drugs. Often they don't work. So the treatment of choice for dystonic tremor is usually surgical therapy. So Botox is experimental. Sometimes it works. For some parts of the tremor, it works very well. For example, elbow extension flexion tremor, bicep triceps उसको लगा दे बड़ा अच्छा effect आता है. लेकिन distal tremor, hand tremor, usually it's very weak. So surgical therapy is the next one.
I have a question. Just keeping the shoulder and the arm swing just aside for a moment. As he gets relaxed, there is no attention to the person. His movements are absolutely normal when he's doing the work. As we are giving attention to him, his movements started very exaggerated, and there is a clear history of depression and anxiety as well. So, are we confident to rule out the psychogenic tremor?
Trying to see कि मैं 2 मिनट में से कैसे जवाब दे सकता हूँ. ये जवाब बड़ा लंबा है. Are we confident now? So, it will be a series of examination before you will be sure. लेकिन psychogenic tremor, you should have to really make an effort to convince yourself of a psychogenic movement disorder. It should not be a diagnosis given easily. क्योंकि जब आपने एक दफा ठप्पा लगा दिया ना, वो उतारना बड़ा मुश्किल हो जाता है. Unless कि आपसे कोई बहुत ही सीनियर डॉक्टर वो देखे, वो कहे जी हाँ ठीक है, नहीं ये नहीं है psychogenic. बड़ा मुश्किल हो जाता है. Number 1. Number 2, often management में इतना बड़ा रोल नहीं है. साइकोजेनिक मूवमेंट डिसऑर्डर्स ऐसे नहीं होते कि आप इस साइकियाट्रिस्ट को भेजेंगे वो क्योर हो जाएगा. आपको उसके साथ रेकॉर्ड डेवलप करनी है. आपको बाद अगर मेडिकेशन ट्रायल्स भी करने पड़ते हैं, हल्की दे देते हैं, लो डोज दे देते हैं, आहिस्ता आहिस्ता उसको कन्विंस करते हैं कि दीज थिंग्स कैन बी बेटर एंड ऑल ऑफ दैट. सो देयर इज स्टिल अ केयर इन्वॉल्वड विद अ साइकोजेनिक पर्सन. एंड नंबर 3, अब थोड़ा लंबा आंसर ये है कि नंबर 1, वेरिएबिलिटी of movements in dystonia is extremely common. And Parkinson का पेशेंट सिर्फ सोच के अपना ट्रेमर रोक सकता है अर्ली स्टेज में, सिर्फ सोच के. Also dystonic tremor, they can just think of it, टेक्स्ट रोकी जा सकती है. So they are actually, although books पे technically लिखा हुआ है dystonic tremor is not suppressible, but it's actually partially suppressible or transiently or temporarily suppressible with various things. For example, इसने जब पेशेंट ने जब अपना ट्रेमर कम किया था, he was clenching fist. That's a very common trick of reducing the tremor. मेरे mentor था, उसका एक patient था, he used to think it may be psychogenic, और मैं उसने कहा मुझे कॉल किया कि why don't you think look at it and give me your second opinion. And what patient used to do was that he would start sitting on his hand. वो बैठा हुआ अपने हाथ पाँव उसके कान के नीचे रख लेता था, ट्रेमर रुक जाता था. These are sensory tricks sometimes, right? Sometimes all it takes is a trick that you have figured out. हमें पता है पार्किंसन में freezing sensory trick से treat की जा सकती है. Tremors के लोग trick ढूंढ सकते हैं, so on and so forth. So variability is not enough. You have to have other positive feature for something for psychogenic, जो एक अलग लंबी discussion है कि वो क्या है. And number 3, if I'm going to call someone psychogenic, I will have to be really convinced, and even I myself try not give a diagnosis on first visit. I have to give it a second.
He used this clip when he's working. He sits on the work, he does this. So when he walks in the past, he used to this. So he gives tips. He's not a person, he's a very happy life. He has kids who are working. He has one son which is competent in examination. बेटा जो CSS कर गया, क्या नाम है? कलीम. So he is a very happy person. He doesn't have any social, any economical involvement. He has a framework which has been seen by so many neurologists and neurosurgeons in Karachi. He used to use this trick. इनकी medications क्या सर, तो मैं कमरे से बाहर नहीं निकलता था. जब बशीर साहब ने दवाई शुरू कर दी, अभी मैं कारोबार कर रहा हूँ, मैं अपना कमरे में बैठा होता था. बाहर सर कहीं नहीं रहता. Currently he is on Inderol and Frentilix, which is an antidepressant, and some remote.
All right, I think let's move on. Do some more cases.
तो नेक्स्ट हमारे पास एक वीडियो सबमिशन है बाय डॉक्टर अजरम व्यास, वो यहाँ पे हैं. तो आप अगर काइंडली हिस्ट्री थोड़ी सी बता दें. थोड़े से तो आपने जो मुझे मैसेज किया था मैंने लिखा, मैं
मेरे नाम हिस्ट्री स्किप करते हैं, सिर्फ फिनोलॉजिकल पे फोकस करते हैं. और भी वीडियोस हैं. Let's play the first video one. अगर आप में से कोई इतना brave है कि वो खुद अभी से मत करना चाहता है and give me your observation, I would love that. And I'm open to that. Otherwise, आप अपने ज़हन में observation सुनाएं, क्या क्या चीज़ आपने pick की है. Then I'll tell you what I'm observing, try to see match them, and hopefully in another video or two you will start giving your parts once you're confident कि हमारी 90% match कर रही हैं चीज़ें. तो लेकिन अगर अभी कोई करना चाहता है, you're more than welcome. But let's watch this video again, and then I want you to tell me, if you want, what are the things you're observing. ट्रेमर को छोड़ के कोई बंदा क्या ऑब्जर्वेशन देना चाहता है? Anybody wants to tell me what they saw except for tremor?
Left side shoulder side.
Okay. What else? Okay. What else?
I think the movements are not symmetrical, and it is very difficult to perform two different type of movements with two different hands.
Okay. What else?
Pepper Fisher is he has got staring look. Looks like blinking is less, probably reduced.
Okay. What else?
And a very violent left side tremors are more than the right one. They are asymmetrical.
And they have different then right side.
Okay. Asymmetry. What else?
Posture is also.
Posture. What is he doing with his posture?
He's falling backwards.
He's falling backward into the right. So then you should question the left shoulder elevation. When you tilted your body, it may already look a left shoulder elevated here. It will become less reliable when someone is off the other side. Then it may not be a true left shoulder elevation. He's kind of starting to fall to the right side, back and right. Okay, what else? Except for tremor. He has parted lips. The lips are usually open most of the video. He has overall cachexia. He looks malnourished, emaciated. Very common in someone with severe generalized tremors. It takes a lot of calories to shake all the time and hard to eat as you live with it. He has sweating. It's very common with persistent and continuous tremor with the generalized. They usually are always sweaty. They have a smell. As soon as you walk to them, you can hear the chronic sweat smell, the clammy skin. He has male pattern balding already. Looks relatively young. Starting to have early hair loss. His temporal hollowing, but that may be part of the whole generalized atrophy, generalized cachexia. And then coming to the tremor itself. Anything else somebody wants to add beyond what we've talked about? It's asymmetric, it's out of sync, it's not in sync with each other, and it's present when it's resting, stays worse, it's present in both legs, both arms. What else? Shuru se bulaye. What is this slapping? Why is he slapping? Let's assume he was not given an instruction to slap. Sorry? I'm not. मुझे थोड़ी इतनी आवाज नहीं आ रही. Okay, tremor तो रुका नहीं. नहीं, ज़्यादा हो रहा है. बड़ा है बीच में.
ये आपने बात पे जोर डाल रहा है कि मुझे ट्रैवल से देखो.
Yeah, could be exaggeration, लेकिन one important thing to remember is proximal temporal tremor. अगर elbow पे tremor है, it will look like ballistic tremor, right? Distal tremor छोटा लगता है. Even degrees में कम ही क्यों ना हो, it will look a big tremor distally. वो distance अब इतना लंबा हो गया. अगर ये 15 डिग्री का tremor है, लेकिन यहाँ 15 डिग्री का tremor will look much bigger, much harder, more kind of like a slap. So I'm pointing this out because just because he's doing this slapping, don't think, oh, he's psychogenic or he's making this up or something like that. And I think he has enough to not need to exaggerate, but you'll never know about patients. Sometimes they still do. Out of sync tremor. Anybody wants to say a guess so far what they think this is? देखिए कोरिया तो नहीं है प्राइमरी इशू तो ट्रेमर ही है सिर्फ ये है कि वो अब इतना obviously resting लग नहीं रहा. It looks far more than resting.
What about myoclonus?
It's not fast enough. Myoclonic has to be very brief and quick and pause in between.
रूब्रल हो सकता है.
रूब्रल हो सकता है क्योंकि distal और proximal दोनों involvement है, लेकिन रूब्रल अमूमन generalized 4 limb में नहीं होता. It will be one-sided at most, but usually one limb.
Could be drug induced.
Possibly almost everything in movement disorder can be drug induced, but a drug to cause this has to be encephalopathic. It has to be not following commands, confused. Drug just pure tremor without anything. Unless he was one thing that can do it would be like methanol poisoning. So rare, very very rare things kind of a drug, not like common drugs will not do.
Thyroid problem.
What?
Thyroid problem.
Thyroid not both proximal or distal tremor. Usually drug-induced tremors are very distal, fine, jerky tremor, not like proximal tremor. And usually drug-induced tremors are arms only. They don't typically involve the legs. Leg tremors are very unusual for a drug-induced tremor.
DPI.
DPI? Or DRPLA? DARPLA? Maybe. Usually common things are common, but yes, DARPLA is possible. So, but if you're saying DARPLA, what's the phenomenology? Right? हमें पहले phenomenological diagnosis पे agree करना है. फिर हम etiology कह सकते हैं कि DARPLA भी हो सकती है, drug induced भी हो सकती है, भी हो सकती है. Phenomenologically, what do you think the diagnosis is?
Almost acidotic acid on left.
And so ectotoid movements when they're not very tremor-like, or they can be. So the classic ectotosis was the finger piano playing movements of the fingers, right? Now there may be some proximal chorea with it, but the prominent feature is still chorea. Here it is tremor. Tremor is the primary phenomenology. It's present bilaterally, both upper and lower limbs. It's severe and persistent, right? It's both proximal and distal, at least in left arm, but more distal in the right arm and both legs, right? Appears to be present at rest, but doesn't fully go away at action. But let's watch that action part, and then we'll come to that more. Let's see when he starts chilling, when he does the actions.
What about the cerebellar outflow tremor?
Ataxic tremor, especially in the left arm. There's a strong sense of that, but not all four limbs. Okay, so what's the effect of the movements on hands, on both hands? This is a complex case, so I'm really pushing the limits here. I'm really going into pointing out certain things that are not very obvious. So clearly, the right side tremor goes away with action. अगर आप last few seconds दोबारा देख लें, ignore the left side. You sometimes have to compartmentalize during the movement disorder examination. So watch just the right side. Forget the left side. Forget the left side. Watch the right side during action.
Goes away.
Goes away. Now the left side does not appear to go away, but that's where I want to push you with. That I think the left side tremor also goes away in the parts that are moving. So watch the left side and then I'll point out a few things. Okay, pause. So left hand tremor before the movements was involving distal and proximal involvement. There was elbow involvement, there was a wrist involvement, there was a proximal involvement. But when he lifts his hand up and brings it to the face, it's only now side to side jerk. There is no wrist movement, there is no finger movement anymore. So some component of tremor is still there, but not all the components. So जब हम rest tremor को कहते हैं कि वो movement से disappear हो जाता है, वहाँ पे हमें ये ज़हन में qualify करना चाहिए कि the movement should involve the joint जहाँ पे tremor है और वो फिर tremor disappear हो. ठीक है? अगर किसी को rest tremor है और मैं उससे कहता हूँ हाथ करीब लेके आओ और दूर लेके जाओ, tremor नहीं जा रहा, तो कहते हैं यार ये persist कर रहा है. लेकिन एक्शन तो एल्बो का हो रहा है, रिस्ट का तो कोई काम ही नहीं हो रहा, राइट? सो व्हाई वुड रिस्ट ट्रेमर गो अवे? You know, in all practical purposes, the wrist is still at rest. So you have to do the wrist movement to say if the wrist tremor. So a wrist tremor that goes away, the movement will be fine. A wrist tremor that is present will continue during the hands going up and down, right? So now let's watch the left hand again, middle से लगाना. While at rest, and try to think कि कौन-कौन से tremors हो रहे हैं, कौन-कौन सी joints पे, किन directions पे. And then watch his movements towards the end to see, okay, क्या वो specific joints के movements कम हो रहे हैं या completely disappear हो रहे हैं कि नहीं हो रहे. So observation 1. Wrist movement, elbow movement, some pronation, supination. So hands opening, closing, the elbow movement doesn't go away, and wrist tremor also doesn't go away. In finger coming to face, the wrist tremor and elbow tremor goes away, but the pronation supination tremor does not go away. Right? So that's observation number 1. The observation now beyond that is my just expert opinion. Okay, now I'm gonna say things that are not just based on this examination. Number 1. हमें जो दो concerns हैं इस patient के बारे में tremor के जो हमें unusual लग रहे हैं. Number 1, they are not in sync on both sides, right? Number 1. Number 2, the tremor doesn't fully go away with action, although some of it goes away or some gets better, but not all of it go away, right? So here's the experience. Maybe it's in some books or not. A young onset PD often has severe tremor which is out of sync on both sides, which is often has mixed types of tremors, multiple joint involvement, where some will not go away with action, will not appear to go away with action, will not even go away with action. अगर आप literature पढ़ें, 5% of Parkinson's disease patients have action tremor. 5%, right? यहाँ मेरे लिए absolute zero होना चाहिए. No, it's not absolute zero. 5% have action tremor. Now I can debate that 5% is exaggeration. Most of them is just not proper examination. But even with proper examination, a true resting tremor of a Parkinson patient, when the tremors are severe, especially in young onset, may not go away with action, but it's still so may have an action component on top of that resting tremor. Okay? So young onset PD throws curveballs often to us. Number one, it's usually fast progressing. Number two, it usually becomes symmetric quickly, within months or weeks. Number three, the tremor is often very severe and seems to be unresponsive to levodopa because it requires very high doses or it's only partially responsive. Number four, it often starts having unusual components of feature like hand slapping or big movements or things like that. And number five often seems to have a strong action component on top of the resting one. You then take that to your advantage and you start using the non-dopaminergic tremor medication, and they respond beautifully because they have a strong action component. Right? Then you give primidone, is my first choice, or whatever you guys have there, triacetanidil or topiramate or something else, and they respond beautifully because they have a strong action component. So far, we've spotted reduced facial expression, cachexia, sweaty, continuous severe tremor, bilateral, is pushing towards Parkinson, but what pulls us away, our tremor unusual hai, out of sync hai, वो पूरा suppress नहीं हो रहा clearly one side. But then when you start paying attention, you realize okay, some component suppressor कम नहीं और दूसरा बाकी, जैसे मैंने mention किया, young onset PD behaves differently. Now let's look at the second video and I'll give you a couple of more observations. Okay, pause it. What's causing him to shake while standing? पहले कुछ सेकंड दोबारा चलाना. Leg tremors. Leg tremors, when present while standing, just like reemergence tremors of the hand, will cause as if they're shaking while they're standing. Plus, as we pointed out earlier, that he has some truncal ataxia, so he's leaning back, he's kind of falling. Now, with cachexia, his ataxia may be secondary. B12 deficiency है, B1 deficiency है, और so on.
We usually see that tremors exaggerated when they become frozen, when they gait become frozen. So is it frozen gait and exaggerated tremors?
I don't know कि उसको चलने का कहा गया कि नहीं. It's possible कि he's in an off state. In off state when he's standing, he will have micro freezes, and that is causing the tremor to get worse.
ऑर्थोस्टैटिक ट्रेमर की जैसा है.
ऑर्थोस्टैटिक ट्रेमर में मेजॉरिटी पेशेंट्स में आर्म ट्रेमर नहीं होता. ऑल्दो कुछ स्टडीज हैं कि अगर आप उनसे हैंड राइटिंग करवाएं व्हाइल दे स्टैंडिंग, यू मे सी ऑन द हैंड राइटिंग सम ट्रेमर, बट ऑब्वियस ट्रेमर नहीं होता. दूसरे दिस ट्रेमर इज स्लो, सो इट्स अबाउट 4 to 6 हर्ट्ज ट्रेमर इवन व्हेन यू आर सिटिंग. स्पेशली लार्ज एम्पलीट्यूड ट्रेमर में अगर आप देखें, it's not fast. It cannot be. So 4 to 6 hertz का मतलब है कि 4 beats per second. So this is 6. This is 4. This is 2. And this is 1. Right? So he's at 4 to 6 hertz or so, which is classic range for Parkinson, right? Parkinson's classic 4 to 6 hertz tremor. Some tremors are close to it. So some people divide it slow resting tremor versus fast. So 3 to 5 will be slow resting tremor, 5 to 7 will be fast resting tremor.
We don't have a history. What's wrong with the drug levodopa-induced dyskinesia?
Why it's not a dyskinesia, right? So a dyskinesia comes in two shapes. One will be a dystonic dyskinesia, right? Shoulder elevation and pulling, with or without tremor or something like that. So far we have not seen much dystonic features. The other form of dyskinesia, which is levodopa-induced, is choreiform, which is the most common form of dyskinesia. The classic chorea, so chorea is chorea, but there is a gestalt or a pattern of presentation of chorea that is different for Huntington's chorea versus Sydenham chorea versus levodopa-induced chorea. So levodopa-induced chorea, I have to show it while sitting, it's hard to do it while standing, is classic proximal trunk, proximal shoulder and hip involvement of a chorea. Not usually face, not usually distal hand. So they're sitting and they go like this. Right? So हाथ बिल्कुल रुके हुए, shoulders चल रहे. They go like that and they start slipping on the chair, right? Because hips or trunk move कर रही हैं. While Huntington's chorea is very classic, equal proximal and distal, bigger pauses. Levodopa-induced chorea is continuous, just continuous. While bigger pauses in Huntington's chorea and has less face involvement. Usually both upper and lower face. So it will be more proximal and distal involvement, foot भी involved है, hip involved है, हाथ भी, face, upper, lower face involvement है, eyebrows involvement है, mouth involvement है, and there's a pause in between. Whether they do, stop, do, sometimes very exaggerated pauses, sometimes brief pauses, but there's feeling of a pause in between. You feel that okay, movement, stop, movement, stop, movement, stop. Sydenham chorea is the classic playful chorea. It's also proximal and distal, less face involvement. It could be complete face sparing, but it looks very playful. So
Sandwich dance.
yeah, exactly, very playful. Not seeing the Huntington's. Huntington's is more staccato, most like that. They'll go like that, right? Sydenham go like that. While levodopa-induced chorea could be very bad. It's just all over the place while they're standing. So usually sitting is the best place to watch for levodopa. No face involvement. Levodopa dyskinesia, chorea, very uncommon to have face involvement. Although there is levodopa-induced dystonia of the face, they can have blepharospasm, they can have jaw dystonia, they can have neck dystonia. But usually face sparing. So I'm not seeing a very clear chorea and I'm not seeing very strong dystonia. So far, just tremor.
Sorry. नीचे VCL.
So ये levodopa है इसको देखो.
So minimal involvement of hand. There's more involvement of foot than we often see. Even foot are more like hand. There's kind of mostly still. Like hips, knees, shoulders, but mostly trunk. They just kind of slipping out of the chair. All right. So I think we move on to the next case.
Start telling me about the
Okay, so we'll start with observation, then phenomenological diagnosis, and then finally think about etiological diagnosis. Besides the tremor, what else did you guys do? Posturing. So the term our mentors, mine and Nabil, used to say was scooping of the hand. Right, the hand becomes like a scoop. You can scoop things up from it. So usually it's this is the normal position. There's a slight flexion at the wrist, and then hyperextension at the fingers. That creates that scoop loop. Okay, not straight at wrist, but slightly flexed and slightly. It's a very classic dystonic posturing that is present. And then usually, even before we make a diagnosis, this guy, usually the rule is if you see a dystonia in a limb and a tremor, then it's dystonic tremor until proven otherwise. I mean, so you have to really find evidence to say, okay, this is a tremor from other reasons besides dystonia. When you see dystonic posturing, then it's dystonic tremor of that limb, if it's in that limb, until proven otherwise, right? So then it makes things easy for you, but or hard that you need to make more closely look. Okay. Play again. While it's playing, any other observation besides the scooping?
Asymmetry. Fluctuation.
Slight asynchronous.
Okay. Anything else? Okay, pause here, go back a little bit down पे उसके हाथ पे focus किया हुआ है. फिर वो है हाथ उसने outstretch किए हुए हैं. Pause. Okay. Watch the left hand closely, and he has a pattern that we call waxing and waning. So tremor is not continuous. So it comes and it stops and goes and comes and goes, comes and it goes and comes and goes. It's waxing and waning. So tremor looks like it's a wave of a tremor that's happening. So picks up, more tremor, comes down, less tremor, picks up, less tremor. So not a continuous. So you can't have a beat with it. Okay, it's regularly irregular. It's almost kind of a behavior around it, but it's irregular. Not completely irregular, which is possible. So dystonic tremor can be irregularly irregular, just unpredictable, random, jerky tremor. It can also be this kind of waxing and waning, which I call, that the tremor picks up and slows down, and picks up and slows down. But true irregular tremor will have a bigger differential. Myoclonic tremor will be the biggest differential for a truly irregular tremor. Just jerks, right? Dystonic is often regularly irregular, has like a waxing waning. So let's watch that left hand tremor. Picked up, before was slow, quiets down, and picks up, and then the amplitude varies, the speed varies, sometimes it's more, sometimes it's less, and so on and so forth. Pause. One dystonia posturing that often gets missed by people is the gunslinger posture. The arms are not by their side, which is a normal hand position when walking or when standing. They're slightly off, that you can see a space, just like people used to carry guns on their hips. They'll have it off so they can quickly draw, right? So that's why we call it a gunslinger posture. And the hand is slightly off. So his left elbow gives you that feel. Unfortunately, camera angle is side and only partial, but front one will tell you better. But even here, I get a sense that there's a slight flexion at the left elbow. It's pulled out like that. So. And again, very strong proximal component, right? You can see the hands slipping. So there's this kind of a movement happening with the hand on top of the distal wrist movement on the left hand. There's a left foot inversion. Did you guys see that?
Yes.
Left foot. We're more clear on this stepping. See how it comes in and lifts up with a foot inversion. Again, could be a foot dystonia. And the left side seems to be worse than right, although because it's bilateral, I don't know if head or neck is involved. If they're involved, then it will be generalized dystonia. If not, then it will be a multifocal dystonia. There are two different foci or more than two foci, but not all attached. But if there is a face involvement, neck involvement, it will become a generalized dystonia. The left foot involvement, left arm more than right. If there was no right arm involvement at all, there would be a left heavy dystonia. That's where I said, always rule out a structural lesion in the brain, like a stroke. All right, move on to the next.
थोड़ी सी हिस्ट्री बता देते हैं. So he is 45-year-old. He is a 45-year-old male. He came to see Professor Salan, I think 2 weeks back. He was diagnosed with writer's cramp in 2005, and he was offered different treatments, but he did not go for injections.
What else we offered?
Yes, and then he over time he felt that the writer's cramp actually improved, and he kept on writing. But then he switched his jobs, and he started typing more. So he now very rarely writes, but typing is his main thing. So say, for like 6 or 7 months ago, he started noticing this thing while typing. So note his hands.
Why don't you explain what you see and how to do it?
Right. So we can see that the right hand, when he is typing, there is excessive extension, especially of the right index finger. The other fingers also have a tendency to extend, especially when he's not using them. There are other things too that you can notice on this camera. Like he's like pronating his right hand a lot, and there is his right thumb actually flexes fairly commonly, but then there is also intermittent extension of the thumb, so I'll have to watch the thumb more.
Why those observations are important?
Yeah.
All things.
Because yeah, so as we know, the most common cramps that happen in the hands are actually flexor type. So flexor type writers cramp is actually maybe 85% of all the writers cramp that you'll get, and then you'll get a classic component of like flexion of the fingers and the metacarpophalangeal joints, and then pronation, and also flexion of the distal like phalanx of the thumb. But then there are like 15% cases of extensor type of writer's cramp, in which there is like a extension. So to confirm if there is actually extension, I'll have to do a more detailed examination maybe. But I think we can clearly say that the finger extension is fairly consistent and common. Then comes the injection planning, and that actually is directly related to which muscles we find active. So, for example, just looking at this video, I think the extensor indicis is the most important muscle that we need to target, and then there is extensor digitorum. And then we have to decide about flexor pollicis longus or not. The pronation that happened that we see in this video could be compensatory. So again, that needs confirmation because if the finger is like extending a lot, then there may be a tendency for him to pronate a lot to actually do what he's doing. So that's why.
Right, so like Nabil said, that if you are a Botox injector, and this is a case that you're evaluating, then observations become even more important because your whole injection planning will depend on which muscles are involved. Another important thing that Nabil said was this compensatory movement. Anybody who has dystonia will always try to fight back, and sometimes the more obvious movement is the fighting back of the dystonia, not the dystonia itself. The compensatory movement may be more apparent. So, for example, like Nabil was saying, that we have to confirm that this the index finger extension is a true dystonic feature. For me, why would that be important to reconfirm that's a true dystonia? Because if he has a finger flexion involvement, and if he has a pronation involvement, then usually both of those are seen with the flexor dystonia, flexor type, the 85%, the most common. Again, my rule number one is common things happen commonly. Yes, it could be this, yes, it could be that, but common things happen commonly. So, I have to convince myself that this is not a flexor type of dystonia. So if I'm seeing an extension, I need to pay very close attention to say a repeated examination and different things to be confirmed that yes, this extension of the index finger is a true dystonia and not like a compensatory movement for the same. The other important thing that Nabil was pointing out in history without mentioning is that dystonias that are only seen during one task are called task-specific dystonia. They are common. Handwriting dystonia is the most common because that's the most common learned task that is done with majority of the people, although that's going away. So the reason handwriting dystonia is more common is because the handwriting is more common. So a repetitive learned task is at risk of causing dystonia. So piano players will get a finger dystonia, or guitar players will get a finger dystonia. Musicians that have flutes or something, they will get embouchure dystonia, lips involvement. We have seen a few cases of Qari, who recite Quran. they get oral dystonia, perioral and lingual dystonia, or mandibular dystonia of recitation. Only during recitation, not during normal speech. Only during recitation.
Do they have a laryngeal dystonia?
Laryngeal is possible again, but that could be a normal speech also. The important thing about task-specific dystonia is that it's common for them to spread from one task to another task, and then eventually become focal dystonia, non-task specific, present all the time, right? In his case, that would be my worry, that his dystonia may not be just typing anymore. He had task writing dystonia before, now he has typing dystonia, but because he's progressing and the dystonia is quite severe during the action, often the more severe the dystonia during task, the more likely it is they also have a rest dystonia, or dystonia regardless of the task, during normal posturing and things like that, and that will be the progression gradually towards a focal dystonia of right upper extremity, more than just task dystonia. And that's very common. Majority will progress on to become a focal dystonia. The task-specific dystonia often also switch if you switch your task. Like this case, he used to write, had a writing dystonia, now he types, and eventually develop a typing dystonia. I saw a case in Shifa with Aslan Saab. The guy used to write with right hand, develop a writing dystonia with right hand, learn to write with the left hand, and then develop a writing dystonia with the left hand 5 years later. Right? So it's common for these tasks with dystonia to jump along to the other task if they change one task to another, if it's repetitive. And then eventually they become primary generalized or focal dystonias.
मैंने नबील से कहा था कि what if he starts dictating and does voice to text?
Yeah.
What will happen then?
Or if he does enough, if he does that for living regularly, then it's possible. Okay. Next.
I think the good dystonias are progressive, but there is actually, I think there is if you follow them long enough, there is you get an idea of the slope of the progression. Like he developed the writing dystonia in 2005, and he developed a typing dystonia in 2025. So you get a feeling that he has a tendency for his dystonia to progress, but it's not fortunately as fast progressing. So if he switches tasks, maybe it'll take another 20 years. Or I'm just thinking that way. So that's one thing too. So,
people with genetic dystonia, do they have risk of developing task-specific dystonia?
I don't know for sure, but I think it's likely, because what I was thinking when I was telling you guys that it jumps the task is that they have now a tendency for dystonia in their brain. They have had that circuit change, and now if they start a new repetitive task, eventually they will have dystonia of that. So if in a genetic dystonia they have a genetic predisposition, then it's probably that they're at higher risk, but often they end up presenting before they have enough time to learn a specific task. You have to learn a task like 10,000 hours rule, right? You have to do that for 10,000 hours over and over again before it's a learned task, and then you have a risk of developing task-specific dystonia. There are many other task-specific dystonia. There's golfers dystonia, people who golf. There's also dystonia in other sports that have been reported.
What happens in dystonia when they stop doing that task? Like writing dystonia disappeared or is it still there? And what usually happens?
So if task-specific dystonia, if it has not generalized, it will not show up in any other activity except that task. So if they stop doing the task, then they will not have dystonia. If they are not doing any repetitive tasks, then I think it's unlikely it will continue to generalize. I think the concern among experts is that repetition of the task is the problem. And that's probably what the reason for dystonia is. It's a hyper-learned situation for the brain. The circuits just over-learned too much. So that's why most experts think that therapy is not good. Because often therapists will use a repetitive task for them to do.
I'm trying to ask that he has stopped writing for the past 20 years because of his dystonia.
Will it get better? So there is at least 2 studies. One study put a cast on the hand to completely immobilize the limb for 6 months. Then, because they developed disuse atrophy, then they did some therapy for recovery afterwards for like 6 weeks or 8 weeks. Both studies. The first study out of Germany showed that the dystonia goes away. The second study out of US showed there is no change to dystonia. It's just right back when they started. So people are split. I personally think it does not go away because it's a change in brain. It may get better because repetition was stopped. It stopped progressing. But I personally think it's a brain change. It would just not undo if you stop doing the task.
Yeah, so just my few thoughts. I think dystonia is not a very fixed movement. I mean, there is a constant struggle between agonist and agonist, and there is this at the brain level, and that's why you might have seen that you start one medication, they are better for like a month, but then that medication like stops working, and then you start another medication, and they are again better for like a couple of months, but then so there is like sort of some kind of conflict going on in the brain, and that actually changes as time progresses. So I think if they are not using the writing arm for like quite some time, there might be a positive change. But then he has a tendency. So because on this exam, this person, I made him write, and he was writing fine. But when he's not writing that much either. So I think there is some dynamic process going on. It's not a fixed structural thing yet. And there's just one comment on Dr. Ismail's point that I think when we classify dystonias, there is like the worst is the generalized, but then there is multifocal, and then there is segmental, and there is focal, and then there is task specific. So task specific is the dystonia in its most limited form. So there is no dystonia that is even more limited than task specific. So what I was thinking is that if it is a genetic dystonia, so it would present as some other fault or so. I think it will be strong enough to present as some other focal dystonia before they actually learn a task, and then they have their task specific is what I was thinking. Thank you. Actually, submitted cases are actually done. जो बाकी cases थे, I actually have a lot of a big library which we can do. We have time, so yeah.
So I have a question for Pranit.
नबील गिला कर रहा है कि आप लोगों ने सबमिट नहीं किए cases.
I have one case if I can share right now.
Yeah, you can send it over to my website.
और मुझे नबील से रानिश से मिला है. Rajesh is just reversing what we spent 30, 50 years, 100 years of teaching. Do history and then do examination. You are telling us, no, I will focus on this examination and neurology. I mean, it just
उसकी वजह ये है कि लोग चीट करना शुरू कर देते हैं, वो हिस्ट्री पे इम्प्रेशन बनाना शुरू कर देते हैं कि ये होगा.
But the traditional, I just did a lecture 3 weeks ago that 90% of the neurological diagnosis made on history, then 7-8% of your examination and rest.
Which is true, लेकिन अगर आपने examination ये वैसी है जैसे एक हाथ बांध के कह रहे हैं, एक टांग बांध के आप दौड़ो. जो आपकी रनिंग की तैयारी हो रही है under stress, कि आपके पास कोई हिस्ट्री नहीं है, you're blind. बल्कि मैं जो पाकिस्तान से वीडियोस आती थी ना जो उर्दू ज़ुबान में होती थी, मैं अपने यूएस के रेजिडेंट्स को देता था ये इसको एग्जामिन करके बताओ ताकि तुम्हें कन्वर्सेशन ना फॉलो कर सके. तो मैं पता चला क्या बात कर रहे हैं, क्या इंस्ट्रक्शन क्या दी गई. Do it and then stress yourself. So in the hardest situation you're trying to make a diagnosis. हम वो वीडियोस देख रहे हैं तो 30 सेकंड क्लिप है, मैं 40 मिनट का एग्जामिनेशन करता हूँ, ठीक है, और साइड से कैमरे का एंगल है, आधा बंदा नजर नहीं आया. But though that's really stresses you out. अच्छा आप बताओगे कि डायग्नोसिस.
But for relearning of myself and for the residents sitting in the room, I think history still plays a key. I mean, yes, this is task-specific examination of movement disorder, but neurology requires history followed by examination.
I agree.
But we also examine that through short cases where history is not very
Short cases जो होते हैं ना उनका ताल्लुक आपकी total diagnostic skills से नहीं, आपकी performance skills से. That is very different. जो long case है वो बताता है कि आप neurologist हैं कि नहीं. लेकिन जो वो task specific जो short case है वो तो सिर्फ ये देखता है कि आपको जी facial nerve कि उनका function recognize करना आता है कि नहीं आता है. But that can be done without history. But I think overall patient care should not go. और जो आजकल ये trend है कि जी आधा prescription 10 सेकंड की वीडियो WhatsApp कर दी, इस पर diagnosis बताओ, और उस पर लोग पूरे thesis भेज देते हैं. I think this trend is not very healthy trend for overall patient care and learning. क्योंकि 10 सेकंड की क्लिप पर लोग जो है वो पूरे इतने फतवे देते हैं और उस फतवे पर इतनी शदीद लड़ाइयाँ होती हैं कि I don't think it's a good idea. The basics still remain in clinical medicine until ChatGPT takes over and we all go home.
And I think someone was also arguing with you that transfer can be done medially as well.
मैं अब आर्गुमेंट करना छोड़ता, मैं माफी मांग लेता हूँ भाई, मेरी गलती है, मैं गुनाहगार,
I understood your stance is that आपने माफी मांग ली है।
क्या कर सकते हैं, लेकिन आप
There was no answer to that. Come and whoever
अच्छा, जब हमारे अभी मेरे पास एक और सबमिशन फटाफट आएंगे ऑडियंस की भरपूर फरमाइश में, जब तक वो लोड होती है एक वीडियो आप देखें प्लीज और टेल मी व्हाट शुड
we all have an option of slow mo in our phones. I think if we record that video through slow mode, that would be more beneficial for us to understand the phenomenology.
Right. Change the speed after.
Sorry?
Once we make a video, we can change the speed after.
मगर अगर हम रिकॉर्डिंग उसको स्लो मो में करते हैं तो वो एक हमने कुछ रिकॉर्ड करके देखे हम बड़े अच्छे रिकॉर्ड होंगे।
तो हमारे जो मेरे रेजिडेंट्स हैं उन्होंने तो ये वीडियो कई दफ़ा देखी है, लेकिन आई थिंक इसको स्टिल अ वेरी गुड लर्निंग वीडियो। Right. So, anybody who wants to comment? It's very uncomfortable watching that video. तो असल में हुआ इसके साथ, चलिए मैं बहुत डिटेल में नहीं जाता, लेकिन एक्चुअली हुआ यही था कि he did have Tourette syndrome, but these are not his tics. So what are they? He did have Tourette syndrome. He had other tics जो आपको मैं दो वीडियो और भी दिखाता हूँ, लेकिन हुआ ये कि he was started on antipsychotics. उसके बाद उसको मूवमेंट स्टार्ट हुई, उसके बाद उन्होंने एंटीसाइकोटिक बढ़ाई, उसके बाद उसकी थोड़ी मूवमेंट्स बढ़ी, उसके बाद थोड़ी सी एंटीसाइकोटिक बढ़ाई, उसके बाद थोड़ी और मूवमेंट्स बढ़ी। जब ये मेरे पास आया, he was on maybe I think 5 mg of Serenase 3 times a day, plus aripiprazole, plus olanzapine, maybe 3 antipsychotics and साथ I think थोड़ी बहुत केम्प्रो। So he was so what is this actually? Right. तो ये चीज एक्चुअली हमने बतानी है कि इसकी जो मूवमेंट्स है, अब they are like first of all they are not it's not the same movement happening again and again, ठीक है, and you get a feeling of restlessness. So he has got extreme restlessness. इसको बिठाना चेयर पे मुश्किल था. I asked him to sit और वो उसका बैठना मुश्किल था. He was so restless. और restlessness is इसकी जो है ना, वो आप देखेंगे it is changing. Different type पे different movements हो रही हैं, और actually जो इसकी leg slapping movements हैं, वो when he stops, he actually doesn't stop because the movement stops. He stops because he gets so tired out that he cannot do it anymore, and just he takes deep breaths, और फिर moaning sounds भी आ रहे हैं जो कि feature restlessness का, और जो फिर जब वो पाँव भी move नहीं कर सकता और हाथ भी move नहीं कर सकता, फिर वो flapping movements करना शुरू हो जाता है, because there is extreme akathisia in this patient.
So mask effect to it.
So he was doing this throughout, like जो 16 घंटे इसके जागने के he was doing that. अब जब उसकी दवाइयाँ बढ़ाई गई, तो और इसको बिठाना क्लिनिक पे, और otherwise such a sweet kid, और जो है,
so why was the dose escalated all the time?
Because they thought that these are tics, because they thought that they were tics and they were treating the tics when actually he had developed akathisia because of the drugs. And the drug, when you increase the dose, the akathisia was worsening because that was the cause. तो हुआ यही कि I was not sure at that time कि ये ticks हैं या लेकिन ये सारी चीज़ों पे फिर हमने what we did was getting him off of antipsychotic slowly, which was actually counter to what was actually being done to him for the past few months to a year. उसके बाद मेरे पास next ये आया after ये वही बच्चा है जो a few months later मेरे पास आया.
हाँ जी, अपना नाम बताओ. मुबश्शिर. अपने हाथ ऐसे करो, शाबाश. सामने ले आओ, सामने. इधर इस तरह.
So he at this time he is like maybe 25% of medications as compared to what he was. Antipsychotics हम सब हटा चुके हैं इस point पे और हमने tetrabenazine दी थी और clonazepam दी थी. थोड़ा सा मैंने उसकी akathisia के लिए propranolol भी start कर दिया. और अदरवाइज जो है ना इसकी अब जो बेसलाइन टिक्स है वो थोड़ी बहुत है, ट्रंक फ्लेक्शन टिक्स हैं या कुछ इस तरह जो आपको अभी इस पे नजर आ रही हैं, लेकिन akathisia इज एक्चुअली मच बेटर. और फिर इसी बच्चे की वीडियो आपको मैं 1-2 साल बाद की दिखाता हूँ. डॉक्टर दानिश से पूछते हैं. अच्छा, ये वही बच्चा है. नाउ ही इज ऑफ ऑल मेडिकेशंस फॉर लाइक अ ईयर. ठीक है. और इसकी आप खैर बाकी डिटेल तो मैं टाइम के लिए वो कर रहा हूँ, थोड़ा स्किप कर रहा हूँ, लेकिन इज नाउ ऑफ
So, what qualifies a movement as tic? If you're unsure, looking at a movement, then what do you need to have to be confident, okay, this is a tic? No, expressibility is not required. What do you mean by stereotypic? Has to be exactly the same, not same, exactly the same movement to relieve what? Urge. There has to be an urge or tension. It could be urge consciously, it could be urge unconscious, like they feel anxious or there is a tickle there or there is an irritation or something that they try to relieve, like in the neck. And the movement has to be exactly the same, and they will keep doing it until they get it just right, and that relieves the urge. And then that's a tic. Otherwise, movement is volitional. It looks very volitional. It could be a combination of anything, any kind of behavior. It could be you have a vocal component, may not have a vocal component, but it has to be exactly the same to relieve a tension or an urge, to get that relief. Yes, then it can have other features. They're usually partially suppressible, at least for a temporary time, but then they often come back much worse. They can wax and wane, they can come and go, they can fluctuate. Some days are better than others, some weeks are better than others, and so on and so forth. And akathisia is a restlessness that is relieved by any movement. So you can tap, you can clap, you can jump, you can run, you can just move in the chair, do whatever, and it will relieve the tension. The tension is usually non-focal, usually in the center somewhere, but otherwise you can hold the akathisia just like a tic. It will build up just like a tic, the tension will, but any kind of movement. So when you ask them to stop one movement, they often replace it with some other movement or bring something else for akathisia. One thing that throws a curveball in tics, so here's a tip to remember. A tic that is long, that there are multiple different movements that have to happen to relieve the urge. So a tic that is long, a complex tic. A simple tic can happen just like neck movement. That's a tic, or blinking tic. But tics can be some very complex movement that they have to go certain this way, and then relax, and then they stop. So a long, complex tic can often happen in portions. We call it forme frustrated, the frustrated form of a tic. So a long tic may not happen always in one go. Over the examination of 30-40 minutes, you may see parts of the tic here and there. But then what you start noticing that A is always followed by B is followed by C, never C before B or B before A. That gradually tells you, okay, it's a one long tic, and you're doing this part and then this part and this part. And that sometimes those 3-4 parts happen in various combination, A with B but no C or D, B with C but no A or D, B, C and D, A, B, C. And that makes it looks like, oh, there's so many different movements going on.
But if you're just paying attention, watching over and over when talking to the patient, this and that, you start picking this up. So that's where usually people miss a tick. That is just prolonged component fractions that you're seeing over and over again. It's a form of frustrated part of one long, prolonged tick that is present. And then there are some ticks that are missed because they are so obvious or commonplace that we do not think of them. What is the most common form of a tick in society? Throat clearing is the second most common. No.
I think repetitive words, the
Cracking knuckles. Cracking knuckles is the most common ignored tick because it's accepted socially to almost become mannerism, a movement that is repetitive, purposeless, but has been accepted socially, will not be called stereotypy anymore, will be called mannerism. The most common mannerism is leg shaking. People sit and they just keep going their legs all the time. A mannerism is a stereotypy, which means it's a repetitive, purposeless movement that is present when someone is distracted and goes away when they pay attention to it. Most common form of a tick that is ignored is the knuckle cracking, but many people are now starting to think it's not a tick, it's just mannerism. But the most common undiagnosed ticks will be throat clearing. That's right. That a tick that should be diagnosed and is often undiagnosed is the throat clearing. It's a very common kind of a tick. Very common. If they feel a scratch, itch in the throat, they have to make that sound to clear the throat. Ticks are often contagious. When I do a tick, some people others start doing this. Right? So that's another feature of a tick. That ticks often, if there are multiple people sitting in the tick, if one does a tick, it starts spreading. Other people start doing ticks. The frequency of ticks is 1 in 25. So there should be at least one in this hall who has ticks.
So is leg shaking a mannerism, or is it just a very mild form of restless leg syndrome? Because it is said that a mild form of restless leg syndrome is very prevalent.
What would differentiate a restless leg syndrome from a mannerism? Right, so a mannerism, they're able to stop without getting any tension in their leg. A restless leg patient, if you ask them to hold or they try to hold their leg, then they have to get up and walk around. They start feeling that itch in their leg, then they have to. And mannerism patient usually will not complain of a creepy crawly sensation in their leg.
There is no restlessness.
Yeah, so a restless leg patient will tell you they have a creepy crawly sensation, they have to move their leg, which could be just shaking when they're sitting to try to relieve it, but often that's not enough, or if they try to hold that, then they have to get up, walk around and relieve their leg. Mannerism typically is not seen when they're laying down in the bed, so some people who have mannerism, they will shake their leg when they're sitting, but almost never when they're laying down in the bed. They usually don't shake their leg when they're laying down.
A lot of people shake their leg or do something with their hands when they're anxious. There's anxiety as well. So how do we differentiate that from a tick? Like how do we, why
all movement gets worse with anxiety. All movement. So getting worse with anxiety give us no information. Any movement, whether it be mannerism, whether it be stereotypy, whether it be tick, whether it be tremor, everything will get worse with stress. Oftentimes my examination is to stress out the patient, to try to get the movement up.
Can I make a comment on mannerism of leg movement?
Please.
It makes the observer restless. One of my fellows does it so much that sometimes I say, I don't say it loud, but I say, maybe ruk ja.
एक वीडियो है दानिश भाई ने एक वीडियो भेजी है अभी फटाफट उसको देखते हैं दानिश ने
How many ticks do you see? Blinking, facial pulling, and
hand movement भी है.
I was not convinced it's not exactly the same. But that could be, playing with the clothes could be a tick, but I'm not seeing the exact pattern. Sniffing, he has a sniffing movement. So start again, let's count. So this was just sniffing. And often sniffing is followed by lip kind of coming up. The lip movement, so that was the first. Then he has this upper face movement with about between nose and eyes. And then he has this blinking tick. I'm still unsure about his gait. He has something odd about his gait. I don't know if that is a tick, a behavior, or he has something else going on.
ABC वाला सर इसका hand में भी है tick.
Left hand. Left hand.
There is some movement, but again, I'm not sure if he is trying to he's just nervous, he's just anxious, or something else.
Sure. The left hand
He also has FLF sign. इसका ना राइट दोनों आइज कॉन्जुगेट राइट पे भी डेविएट होती हैं in the beginning of the movement.
इसको विल्सन के लिए चेक करना चाहिए. So we have few jobs in
Eye rolling tick. Yeah, that's the tick. Yeah. So he has a tick of his upper face like that he does very frequently. And he has the blinking tick, sniffing, and then he has the eye rolling tick. Now I'm not sure if they are just one complex tick that he's showing pieces of, which is possible. All of this is just one continuous big tick, or are these separate ticks?
Restless legs की तरह restless hands भी देखेंगे.
Usually after neuropathy, not idiopathic, but yes, neuropathy के बाद मैंने देखे हुए कुछ reports.
Augmentation के बाद progression of the disease when it goes up.
ये लेकिन isolated भी मैंने देखे हैं पर but that's usually related to neuropathy or radiculopathy.
हाँ? उसको restlessness नहीं है, urge to move. मैंने वो स्माइल में long time back पहली दफा मैंने एक moving toes देखा. That was about 20 years back. Moving toes बहुत ही weird था उस वक्त तक. लिटरेचर में भी इतना नहीं था जब मैंने नहीं क्या बोला. फिर उसके थोड़े अरसे बाद स्माइल में एक और देखा जिसमें डांसिंग टोज थे. लेकिन हम उस वक्त हमें कोई इतना लिखने का शौक
भेजा था सर नहीं लिया ह्यूमन डिसऑर्डर वाले रिजेक्ट कर दिया.
प्रेजेंट किया था हमने कहीं दो केसेस हमने
लिखा था लेकिन वो नहीं लिख सकता. ये भी कॉलेज का नाम नहीं लगा सकते थे ना.
ये भी एक शॉर्ट सी वीडियो मेरा पेशेंट है उसकी आप हैंड राइटिंग देखिए. ब्राइटनेस वहाँ पे ना ये अगर सामने वाली लाइट्स बंद हो सकती है.
इसका फूड क्यों निकाला था?
असल में वहाँ पे बहुत अच्छा ब्राइटनेस की वजह से नजर ही नहीं आ रहा वर्ड. So वहाँ पे I'm sorry again नजर नहीं आ रहा लेकिन मैं ये बताना चाह रहा हूँ कि the words are very different based upon the posture that he is using. So as soon as we change the posture, they just go away like they were never there. तो थोड़ा समय maybe इस पे अगर आप देख सकते हैं देखना चाहें.
The way he holds the pen, उससे जो है जब से ये different तरीके से मैंने पकड़ा है इसे.
He was putting pressure on the wrist.
The way he holds the pen.
So is it because in the first position his hand was resting on the table and as soon as
So it's not the resting tremor. मतलब point ये कि ये dystonic है मतलब ये task specific tremor which is usually dystonic otherwise. लेकिन उसमें भी यही बताना चाह रहा था कि जो dystonic tremors होते हैं ना they are very position dependent or specific. जबकि as compared to the other tremors are like essential tremors, they are just oblivious to different positions. They just be there. तो इसमें है ना different muscles के posture change करने पे अगर tremor change हो रहा है significantly तो it is dystonic under one other.
Yeah. Well, I think we can stop here unless someone has any question. I'm happy to take a question. All right. Thank you, everyone. Thanks for joining.